Our first speaker is Natalie Ashari, and she's going to speak on, is this infection of peripheral ulcerative keratitis?
Thank you, Dr. Deng, and also I'd like to thank Drs. Lee, Deng, and Patel for putting this great subspecialty day together, and wonderful that so many cornea colleagues stayed until the very end. That was the Freudian slip, retina. Oops, they usually stay behind, and that was what I was talking about. Finally, we stayed. So I'm going to talk about peripheral ulcerative keratitis. These are my financial disclosures, but nothing relevant to this talk. So what is PUK? PUK, peripheral ulcerative keratitis, is crescent-shaped destruction, inflammation of the cornea with corneal epithelial defect, stromal inflammation and infiltrate, and melting necrosis and perforation of cornea at the end that can be associated with systemic disease. So PUK may precede the systemic disease, but there is a tendency for it to occur following systemic manifestations. It was Joe Tauber and Steve Foster who reported that PUK was the initial manifestation of collagen vascular disease in 50% of cases. And in a follow-up paper looking at about 500 eyes with scleritis, they reported the association of scleritis with PUK. So why periphery of the cornea? Well, the blood supply of the periphery of the cornea comes from anterior ciliary arteries that extend into the clear cornea, about 0.5 millimeter into the clear cornea. So we have the presence of immune cells. We have more Langerhans cells and higher concentration of IgM and C1 concentrations there. PUK is adjacent to conjunctival, episcleral, and scleral inflammation. So this adjacent tissue exacerbates the course of PUK and may actually cause complications such as perforation of the cornea, as we could see about to happen in that picture. So PUK may be associated with various ocular and systemic infection and also non-infectious disease, bacteria, viruses, fungi, chlamydia, systemic connective tissue, vasculitides, all of them, and as well as dermatologic disorders that can cause PUK. The cornea signs of all of these collagen vascular inflammatory diseases is similar. So even though PUK may be the presenting sign of these potentially life-threatening systemic disease, it may develop as a complication of scleritis or especially the necrotizing form. So systemic workup is essential for these patients because patients with collagen vascular disease-related PUK, they often require very aggressive systemic treatment to stop the progression of corneal destruction. As you could see, this patient has PUK and also some of that necrotizing scleritis, as you could see. So there are a number of possible etiologies for these peripheral diseases, from idiopathic to marginal keratitis to PUK, Morin's ulcer, all of the infections, the bacterial, viral, amoeba, collagen vasculitides, specifically and more commonly rheumatoid arthritis, those ANCA-associated vasculopathies, as well as SLE and polyarteritis nodosa, and then again, a whole slew of other infectious diseases. So what do we do for workup? Because of everything that goes on and because of all of the possibilities, those complete ocular history, including history of contact lens wear, current and previous medication, asking about trauma and surgery, comprehensive systemic review to rule out the systemic diseases that could be associated with PUK that may not have shown yet, and complete ophthalmic examination to exclude local pathologies, and of course, culture in those suspicious cases of infection. Reza Dana with Pedram Hamra as well as Foster, Steve Foster, have written a number of times on differential diagnosis of peripheral ulcerative keratitis, including all of those infectious possibilities, as well as the systemic, autoimmune, vasculitides, and even dermatologic disorders. Now, in the differential diagnosis of PUK, we also have the possibility of Terriens versus Morin's, and the PUK is painful versus Terriens, which usually affects the younger patient, is painless, and then we have the Morin's ulcer, which starts in the periphery and then goes more in the centripetal effect. This is one of my patients who has Terrien's degeneration, and unlike the general kind of these patients, this patient has bilateral corneal perforation, is a jiu-jitsu athlete, and as you could see on the anterior segment, OCT has very thin cornea in certain areas. So how do we treat these PUK patients? So management of corneal disease will be disappointing if we just treat the cornea, unless we treat the systemic disease and treat it very aggressively. And then the treatment of the systemic autoimmune disease, however, has very good effect, beneficial effect on ocular manifestations. So we treat within, out, as opposed to out, in. We treat those bacterial viral infections that may cause the PUK, and then lubricate the eye, as most of these vasculitides have dry eye problems and tear film abnormality as well. Also, washing it out, it dilutes the harmful inflammatory proteins that we may have. But that alone, the ocular treatment, is not enough. We need the systemic immune modulation, perhaps the systemic corticosteroids as the first-line therapy for acute treatment of PUK. But then often we are unable to really inhibit disease progression or overcome the autoimmune disease when we just use the systemic corticosteroid. These patients need heavy gun, the immunosuppressive drugs, or biologic agents to go after the true treatment, the true cause of the condition. We also have the surgical management for acute perforation of these patients, from tectonic procedures, tissue adhesive, bandage contact lenses, lamellar graft, tectonic corneal grafting, amniotic membrane transplantation, and of course our own penetrating keratoplasty. But we got to remember that these patients, if they are not treated with systemic immune suppression treatment, their PK doesn't do well. And as you could see in this Kaplan-Meier curve, the patients who got systemic immune suppression versus the patients who did not get systemic immune suppression, and the results and the survival of their PK. So in conclusion, PUK includes a group of corneal infection and also inflammatory diseases that can be really life-threatening autoimmune collagen vascular disease. So it is on us, ophthalmologists, as some of these patients present to us first, to diagnose and work with rheumatologists and treat them systemically, as these conditions can be initial sign of systemic disease.